Okay, so we'll discuss surface anatomy, abdominal organ projections, how you can project the location of some internal organs from the anterior abdominal wall. Now, the abdomen can be divided into 4 quadrants and 9 regions. The 4 quadrant division will give you the right upper quadrant here, the left upper quadrant, the right lower quadrant, and the left lower quadrant. Now, there's some projections that allow you to know what organs to expect underneath each of these quadrants. So someone tells you, I feel pain here. Your possibilities are, could it be the liver? Could it be the stomach? Could it be the duodenum? Someone tells you, I feel pain here. Your possibilities are, could it be the spleen? Could it be part of the transverse colon? Could it be part of the descending colon? Someone feels pain here. You're thinking, could it be the appendix? Could it be part of the cecum? And so on and so forth. So now the 9 regions divides the abdomen into the right hypochondriac region, the epigastric region, the left hypochondriac region, the left lumbar region, the umbilical region, the left, I've already mentioned left lumbar region, the right iliac region, the hypogastric region, and the left iliac region. And of course, if you have these 9 regions demonstrated on the anterior abdominal wall, you have the liver sitting under the right hypochondriac region, you have the liver and part of the stomach in the epigastric region, you have the spleen under the left hypochondriac region, you have part of the small intestine, part of the transverse colon, part of the descending colon under the left lumbar, and so on and so forth. So now these same projections allow you to, when there is a need for a surgical procedure, to know, okay, in what direction am I going to make my cut? If you by your projection allows you to assume that the appendix is sitting underneath the right lower quadrant, it will then make sense to make a cut that goes in this direction. If you're looking for the appendix and you go cutting in the midline, the upper midline, that is not a very wise cut or a very wise move. It just shows that the personnel is clueless as to the projections of the abdominal organs from the anterior abdominal wall. So this is a cadaveric specimen. It just means a cadaver is a dead body whose body is being used for anatomical studies to be able to study the locations and the structures of the organs of the body. This is the liver, and the liver is said to have the right lobe and the left lobe, and of course there's the falciform ligament. This is how the liver sits in a normal human being. Now the posterior view, that's as though you're looking at the liver from underneath or from the back. This is what it looks like. The gallbladder is sitting there. Then you have another additional lobe. You have this ligament. This is the left lobe and the right lobe. This is still the liver. Now, this is the stomach. The stomach is said to have 2 curvatures. There's the lesser curvature, which is the smaller one. You can see it's a smaller curve, and there's the greater curvature, is a bigger curve. And the stomach has 3 major parts. There's the fundus, which is the upper part. There's the main body of the stomach. Then there's the pyloric region right here. Now, the pancreas is also another part of the abdominal organ. It's sitting behind the stomach, and it is being hugged by the duodenum, and it secretes enzymes into the duodenum that from there enters the whole gut and helps in digestive processes. Now, greater omentum is like a sheath, like an apron that covers the internal organs, in this case the intestine. That's where the blood supply, the nerve roots that feed the bowel loops are seated. They are located in. When you watch surgeries, you probably see them reflect or work on this greater omentum. Is this fatty sheet that looks like a covering on top of the intestine. Still the same greater omentum. This is how it sits naturally. In cases when there is inflammation and the likes, that it can move away from its normal position. So it sits like this naturally. Then after the greater omentum has been reflected away, you then see the intestinal loops that are lying beneath it. In this case now, the greater omentum has been reflected away. Then of course the ileocecal junction and the appendix still part of the intestinal loop is the rectum and the anus, and here this is the bladder. This is a male. This is the bladder coming down here. This is the prostate, and of course this is the urethra. This is where we put in a catheter. This is the testis here. Now this is a female specimen. This is the rectum, and this is the anus. This is the uterus. This is the space called pouch of Douglas, when we tell you there's free fluid within the pouch of Douglas. And of course this is the bladder. So endoscopic anatomy allows you to look through from the mouth, through the throat, to the esophagus, to the stomach, to the small intestine, to the large intestine. And if it's through the anus, from the anus to the large intestine, to the small intestine, then of course the stomach if there's a need, and so on and so forth. So looking through, this is the patient lying supine, lying on their back. The tube goes in through the mouth. This is the upper third of the esophagus, and this is what it looks like endoscopically. This is the middle third of the esophagus. This is what it looks like endoscopically. This is the lower third of the esophagus. This is what it looks like endoscopically. Of course, still while a patient is still undergoing endoscopy, the cardia of the stomach looks like this. The upper body of the stomach looks like this. The middle body, you can't see it. Then the lower body, the antrum, the pylorus, and so on. So basic radiological anatomy, the GIT. When we take an X-ray of the anterior abdominal wall, it would usually look like this. And I know sometimes it could be dazing and daunting to try or even attempt to interpret what you're looking at. But this picture makes it so easy. If you have a typical anterior abdominal wall X-ray in your hands, on the right is the ascending colon. Then coming up just underneath the diaphragm is the transverse colon, and of course coming down is the descending colon. Then this X-ray goes a little higher up to the thoracic region. Here we can see the liver. It's that shadow there, and you can see the stomach with gas in situ, which is why it is black. Once it's black, it is gaseous, so you have hair, which is why the lungs will look black and the heart will look white, because it's dense, it's a dense muscular structure and there's fluid inside, it will look white. Now the liver looks white too because it's a dense muscular structure, it's a smooth muscular structure. So a patient who undergoes abdominal CT, it could also look like this. The interest for the GIT structures. Here you have the liver, here you have part of the ascending colon, here you have the small intestine, you have the spleen here, you have the stomach here, you have pancreas and some other structures. And if you have a transverse cut of the abdomen, you would find the liver here, the stomach here, based on the line of cut. This is also another line of cut that allows you to see the hepatic artery, the neck of the pancreas, the splenic artery, and the others. So some clinical anatomy conditions of interest. Situs inversus is when there is rotation in the opposite direction. It's not so common. But what happens here is the heart that should be on the left goes to the right, as you can see here. The liver that should be on the right goes to the left, and the whole of the intestine is rotated the other way, such that appendix that should ordinarily be on the right is seen on the left. Now, if these patients like this have not had a workup that will help suspect that there's an abnormality going on, it could be when there's a need for a surgical procedure, that you then find that, oh, the anatomy of this individual looks different. It's not looking usual. I'm looking for the appendix, I can't find it on the right. That may then lead to a suspicion of, could this individual have situs inversus? Then, of course, after further investigations, could be a CT, could be MRI, you then find that all the structures have been transposed to the opposite side of the body. Then esophageal hernia. Intestinal obstruction is also another one. So herniation, this is hernia. Usually you have a defect in the anterior abdominal wall that allows the intestine, the mesenteries, the omentum, and the likes to come out through the pouch. And now when this comes out and is not able to return, and there is compromise of the blood supply, it could be said to be obstructed. From obstruction, it could lead to gangrene and death of this part of the intestine that is in the outpouching. Then adhesion is when you have fibrinous bands joining two parts of the intestine, such that it causes a kinking. Once there is that kinking, the food products or intestinal products is not able to move freely, and an obstruction sets in. The intussusception is more common in children. Is when the intestine runs into each other like this. So there's another intestine that is sitting inside another one, such that the intestinal product again can also not have a free flow. The volvulus is when there's a twisting of the loop of the intestine, twist on each other. It will also cause obstruction. This is a radiography study. This is an X-ray of a very enlarged liver, and of course the patient needed to do a CT, and you can see the liver is so big that it's taking up more than half of that transverse cut of the individual's abdomen. Then the final and common abnormality is hemorrhoid. Hemorrhoid is when you have dilatation of the vessels within the rectum. You can see this is dilated, this is dilated. The problem with these ones is that these vessels can rupture and bleed, and the individuals is stooling blood mixed with mucus and the likes. And of course these vessels are at risk of getting infected, so the cycle keeps perpetuating itself. Okay, thank you very much. If you have questions, please ask me when we see in class.